Introduce one of the best speakers, I think, in the whole area of cardiovascular risk, and that is John Deanfield. John is the British Heart Foundation and Van der Velde Professor of Cardiology at the University College UK, and he's also a great pal, and I look forward to hearing your talk, John.
Well, thank you very much, Tom and Adrian, for giving me the graveyard slot at a meeting. If you're still in the audience, you should be not looking like these guys on the left here, because I think this topic of lifetime management of cardiovascular risk really is the next change in our thinking about the way in which we're going to reduce cardiovascular disease, not only in the population out there at large, but in our patients and indeed in ourselves. Because it's a sobering fact that despite everything we've achieved and we may achieve with novel therapies, that we're still at very high risk of developing a cardiovascular complication during our lives. About almost 50% of us are scheduled to have a cardiovascular event in our systemic circulations, our coronary circulations, or our cerebral circulations from diseases like atherosclerosis. So this really is still the major key to population health. Now, the idea that we've got on top of cardiovascular disease was really put into perspective by a publication in The Lancet looking at global cardiovascular disease levels and trends over the next decade or so, which showed rather soberingly again that there was likely to be a 20% increase in cardiovascular disease in the next decade, largely born in low and middle income countries. And this is due to a rise in cardiovascular risk factors, despite all of the efforts that we have made over the last decades. Now, the reason for this was very nicely summarized by Alan Gregg at the Rockefeller Foundation, who wrote that the problem was that the human race has a long experience and a very fine tradition in surviving adversity. But the problem now is we face a task for which we have little experience, the task of surviving prosperity. It is the novel exposure to lifestyles that perhaps our genotype and our environment has not previously prepared us for that is actually causing the problem of premature cardiovascular disease. Now we're in an incredibly fortunate position in cardiovascular disease compared to other system diseases like cancer and the like, because we know most of the modifiable cardiovascular risk factors that will actually contribute to developing clinical problems like myocardial infarction and stroke. You only have to look back a decade to Salim Yousef's InterHeart study, which showed in 52 countries around the world an identical relationship between risk of cardiovascular events, in this case myocardial infarction, and cardiovascular risk factors in different populations. 9 potentially modifiable cardiovascular risk factors, including the usual suspects, smoking, cholesterol, diabetes, blood pressure, and the like, accounted for more than 90% of the heart attacks they saw in this large study of more than 15,000 patients. So we know what it is that is causing cardiovascular disease. We've had a real problem in communicating this information to our colleagues and to the public. Now, most of us are treating cardiovascular risk factors in quite an old population. In clinical practice, patients usually come to us from the age of about 50 and onwards when they start to develop cardiovascular disease. They have severe, established underlying atherosclerosis that underpins the clinical presentations of stroke and heart attack. And we miss a huge opportunity to modify that long preclinical phase of this disease, when I'm going to show you atherosclerosis is building up in all of our circulations. Now, this was highlighted again by the Lancet's editorial looking at the global burden of disease study and suggesting that in the UK, while we've been rather pleased with our efforts in reducing cardiovascular events over the last 20 years, we've got still quite a long way to go. And we lag behind in terms of reduction of premature mortality, and big progress, they suggested, will need to be made in terms of public health, prevention, and I point out early intervention for managing these chronic diseases in the future. Now, why am I going on about early management of atherosclerosis? Well, first and foremost, this disease doesn't start in middle-aged and onwards. It's a disease of the young. This was really nicely emphasized by a recent study from the Cleveland Clinic from Murat Tuju and colleagues, who looked at the coronary arteries of young Americans in the modern era dying of non-cardiac related causes. On the left, for example, you see a coronary artery looked at with intravascular ultrasound from a 32-year-old woman who died in a car accident near Cleveland. Notice with the red arrow a prominent atherosclerotic plaque already present in that young lady's coronary circulation. Notice also how important the remodeling of the arterial wall is in the development of early atherosclerosis. These lesions that we're all building up don't start by encroaching on the lumen of our coronary artery and causing symptoms. They remodel the artery outwards for decades before there's a clinical problem. If this woman had just happened to have a coronary arteriogram before she died, it would have looked entirely normal. Now, we could speculate how many of you survivors of this meeting sitting in this room here this evening already have coronary arteries that look like this. Actually, you don't have to speculate too much, because if you now look on the right-hand panel, these are the prevalences of coronary atherosclerosis detected by intravascular ultrasound in young Americans in the modern era dying of non-cardiac related causes. If you look at the first column, that's the teenagers. About 1 in 20, almost 1/5 of American teenagers already have early atherosclerosis. And rather worryingly for some of us in this room, if you look at the 50-year-old column on the right, more than 85% of the hearts they examined had multiple atherosclerotic lesions. So pretty well all of us are on this rather steep slope to developing substantial amounts of this disease in our coronary and peripheral circulations. And instead of just treating this disease during its late clinical manifestations, we ought to be asking, what is it that is initiating this disease from such an early stage? And what is it that's driving this emergence of atherosclerosis over many decades, which will ultimately lead to so many clinical problems? So lots of evidence is emerging in the last few years that one of the key factors is chronic exposure to modifiable cardiovascular risk factors. It is the area under the curve, perhaps, of exposure to risk factors that is driving this disease over many decades. And what this does is to set up the opportunity to test whether early intervention might actually be very important in terms of leveraging future gains in terms of reduction in cardiovascular risk. And this was nicely illustrated by Donald Lloyd-Jones, who went back to the Framingham database, that classic cardiovascular outcome trial, and asked a very simple question. Lloyd-Jones asked what was the relationship between the risk factor profile in this population at the age of 50 and future risk of cardiovascular events. Well, if you can see in yellow on the left here for a man, if you got to 50 years old in Framingham with all of your risk factors in good shape, your future chance of having a stroke or a heart attack in the next 30 or so years was just 5%. On the other hand, if you were a man and you got to 50 with 2 or more of your major cardiovascular risk factors at above optimal levels, it was usually smoking, cholesterol, and blood pressure, that risk rose to a whopping 69%. You could argue then that it's all over by the age of 50. The die is already cast in terms of your future cardiovascular risk. This sort of work really emphasizes how important the interaction between risk factors and the arterial wall is during that long 50 years before clinical disease begins to emerge. Now, I would love to be able to stand here and show you a randomized clinical trial that proves that early intervention at this early stage results in lower risk of cardiovascular events in later life. And of course, that sort of trial will never be possible. It would take much too long to randomize patients in their youth and track them to future cardiovascular outcomes. But the genetics that we're beginning to see really supports this idea of exposure being a key driver for future cardiovascular events. You've already seen this slide in a previous presentation. This comes from the ARIC study in the United States, looking at the PCSK9 mutation, which is now targetable, as you've heard, in clinical practice. But it looks at this mutation in terms of its impact on LDL cholesterol over life and its potential impact on future cardiovascular disease. They found a mutation of the PCSK9 gene, which was present in 3% of the black subjects in this cohort. It resulted in a 28% lifetime lowering of LDL cholesterol. That 28% lower LDL cholesterol over the life of these individuals translated to a very impressive 88% reduction in cardiovascular events. Remember, when you give a statin in clinical practice, you're aiming to lower the LDL cholesterol by about 50%, and you're very pleased if you see a 25, 30, maybe 35% reduction in cardiovascular events. This, if you like, is compound interest from early intervention for future cardiovascular gain. Now, this applies in more recent studies to a whole range of different genes that affect LDL cholesterol. This was a meta-analysis reported on 9 polymorphisms in 6 genes affecting LDL cholesterol levels. And it makes the point that if you lower your LDL cholesterol by genetic reasons, in other words, you have a lower LDL cholesterol over your life, the impact on future cardiovascular risk is much greater than an equivalent degree of LDL cholesterol lowering achieved in later life with a pharmacological intervention. Again, exposure to the cholesterol being key in determining cardiovascular risk. Now, so far I've just talked about cholesterol, but clearly this is potentially true for pretty well all of the major cardiovascular risk factors. Let's start with cigarette smoking. We all know that smoking is bad for you, and that the longer you smoke, the worse it is in terms of your cardiovascular outcome. This was a paper in the New England Journal of Medicine last year, more than 200,000 people who gave up smoking, looking at the model of the impact of stopping smoking at different ages. If you smoke from middle age, on average, you lose about a decade of life expectancy. If you stop smoking in your 40s, you regain about 90% of that lost decade. However, the later you stop smoking, the less of that lost decade you'll recover. Classic example of exposure to the risk factor driving the clinical complications and the opportunities, perhaps, from early intervention. This is a recent paper that I think Mark Caulfield presented this morning. This is work from our group looking at lifetime exposure to blood pressure in relationship to cardiovascular complications. What it looked at was more than 1 million subjects without cardiovascular disease over just a 5-year period, and looked at the lifetime risk of hypertension from the age of 30 years. Hypertension at 30 years of age conferred a 5-year loss in life expectancy in this population. Again, a very nice example of how cardiovascular complications, and you see the series of the different cardiovascular endpoints, were related to exposure to blood pressure over time. Now, the nice hypertension report that came out in 2011 was the first major report on cardiovascular risk factors that really got this idea. Very perceptively, in NICE, in the blood pressure guidelines, they wrote that short-term 10-year risk underestimates lifetime cardiovascular risk, particularly in young people with hypertension, and that lifetime risk in this age group could be substantial. Lifetime risk assessments may be a better way to inform treatment decisions and to evaluate cost-effectiveness of early drug therapy. Very perceptive and way ahead of the cardiovascular guidelines until recently. Now let's take a look at how we've communicated this message of early management of cardiovascular risk for potential future gain to our colleagues and to the public. These are the European Society of Cardiovascular Prevention guidelines published just 2 years ago. And these are classic representations of the way in which pretty well every one of the cardiovascular risk guidelines has assessed and communicated risk. All of them are based on 10-year absolute risk of having a cardiovascular event. This was very appropriate 20 or so years ago when the cost of treatments that lowered your risk was very high, the safety was uncertain, and the clinical benefits were as yet unproven. In that era, it was very appropriate to try to limit the use of drugs to lower cardiovascular risk factors to patients who were at the very highest level of cardiovascular risk. That, of course, has changed now with the much greater information we've already heard about the safety and benefit of classes of drugs like statins and indeed blood pressure lowering. Let's take a look at one of these tables. This is age, cholesterol, and blood pressure in men and women. You'll notice immediately that a female can be 55 years of age have a blood pressure of 180 and a cholesterol of 8 and still have a very low short-term risk of cardiovascular disease, and be reassured by this sort of calculation. Notice also that if you're a man over the age of 60, it almost doesn't matter what your level of cholesterol or blood pressure are. You're at high cardiovascular risk just based on your age and your sex. Now, what this does is to disenfranchise young people, and especially women, from getting effective cardiovascular risk factor guidelines. Now, 2 recent guidelines have appeared in the last year trying to alter that approach to cardiovascular risk reduction. The first was the ACC-AHA guidelines on lipids, and the second is the recent NICE guidelines on lipids, both of which have taken the same essential approach to this problem of trying to extend cardiovascular risk reduction to a wider segment of the population. Both of them have maintained emphasis on 10-year cardiovascular risk, but what they've done is to lower the threshold, lower the bar above which you're going to be recommended intervention. In the United States, they've lowered it from 20% to 7.5% absolute 10-year risk, and the NICE guidelines in the UK have recommended a slightly more conservative threshold of 10%. Both these guidelines have been highly controversial, both in the medical and in the lay press, because what they do is to extend the indication for statins particularly to a very large segment of the population. These are estimates of what the American guidelines will do to statin prescribing in the United States, recently published in the New England Journal of Medicine. The new guidelines, in terms of the American population based on 7.5% threshold for the use of statins, will result in statins being recommended to about 56 million people in the American population. Dare I say it, if you look at the bottom, mostly old men, for the reasons I've already showed you. So the big question is, does this make sense, and does this tally with the sort of patients you see in clinical practice? Here are a couple of cases to illustrate the tensions around this type of way of recommending cardiovascular risk reduction. Here's an elderly black man published in a recent paper in the New England Journal of Medicine. He's 79 years of age. I apologize for the American units. This comes out of the publication. His cholesterol is vanishingly low. His HDL is okay. His blood pressure is perfect. He's got nothing else wrong with him. But his calculated 10-year risk of a cardiovascular event or stroke is 13.7%. He qualifies for statin use because his 10-year risk is above 7.5%, based entirely on his age and his sex. Here, in contrast, is a woman of 46. She's got a high cholesterol, she's got a high blood pressure, she's already taking antihypertensive medication. She's clearly at very high cardiovascular risk. Her 10-year risk calculates out at 2% because she's young and because she's female. Cholesterol is high, blood pressure is poorly controlled, but she doesn't qualify from getting a cardiovascular risk factor intervention recommendation because she's female and because she's young. Now, how many people are there out there in the population who are like this, who are at short-term risk, which is low, but have a high lifetime risk of a future cardiovascular event? Well, Marmer and colleagues estimated that about 56% of the American population, that's 87 million people, have a 10-year risk of less than 10%, and yet had a lifetime risk of 40% or greater. Probably half the people in this room will fall into this category. Now let's look what happens using the American type of guidelines, this threshold for 10-year risk, when you see a young patient who comes to your clinic with a modifiable cardiovascular risk factor. Here's a young man, he's very fit, he's got no family history, he's slim, but he's got an LDL cholesterol that's really very elevated at 180 and a total cholesterol of 310. The American guidelines don't make any recommendations of what to do with this man because there's no randomized trial of 25-year-olds receiving therapy. Now, if he gets to the age of 40, to get into the guidance of that the American guidelines include, his 10-year risk would be 3.1%, and he would be sent away. he'd have to reach 58 years of age to cross that 7.5% threshold to warrant advice to take a statin. I agree with Stan Hazen in a recent publication that waiting for people with risk factors like dyslipidemia to reach middle age before starting appropriate therapy is a failure of prevention. And yet that's what we're driven to do by these risk factor guidances based on 10-year absolute cardiovascular risk. So what we've done in this country in a long considered publication, the JBS3, is to take a rather different approach, targeting not just patients at high cardiovascular risk, but also trying to develop a guidance that would inform management of cardiovascular risk in the rest of the population. Every one of us can get guidance that is personalized from this type of approach. And this was published in March of this year, and there's a recent app I'm going to show you which allows you to do it on your phone, and that's downloadable for free. What JBS3 targets is investment in your arteries. Early intervention for future cardiovascular gain is emphasized. It is personalized to your particular risk factors. It is a lifetime approach to cardiovascular disease prevention. Now, we use a new calculator with metrics that we believe, although they need to be tested, are much more easy to understand and much more easy to communicate to the public. And most importantly, those metrics are linked to potential gains that you can demonstrate in front of your patient by lowering those cardiovascular risk factors and showing them that that gain is amplified by doing something early and maintaining it over their life. This is designed to empower individuals to take control of their cardiovascular health, not just by taking statins when they reach a very high level of cardiovascular risk, but by modifying their lifestyle to produce a benefit in terms of their long-term cardiovascular outcome. I'm not going to bore you with the details of the JBS3. There's a 2-page summary which takes about 5 minutes to read, which I think gives the essence of this approach. But essentially, the top half of our algorithm is exactly the same as everyone else's guidelines. If you've got cardiovascular disease or you're at very high cardiovascular risk, especially when you have comorbidities like diabetes and kidney disease, you don't need your risk calculated. You need aggressive cardiovascular risk factor management. But what JBS3 allows you to do is to have a conversation about cardiovascular risk with the rest of the population as well. Here's an example. I'm going to show you 3 examples that make the point about lifetime risk. Here's a 35-year-old woman who she smokes, she's got a high cholesterol, you can see those on the right, and she's got a high blood pressure, and she's got a family history of premature cardiovascular disease. That's pretty well the full house in terms of future cardiovascular risk. We tell her what her heart age is. That's the age equivalent to the general population in terms of cardiovascular risk. That 35-year-old woman has a heart age of 47 years. Now that's become, in our early assessments of this approach, a very intuitive way of telling people that their cardiovascular risk is not at its best. People don't like to have a heart age that's older than their chronological age, and the first thing they ask you is what they can do to get it back down to their real age. I like this thermometer approach as well. This tells you, with your particular cardiovascular risk factors, when you can expect to have your first heart attack or stroke. How long are you expecting to live healthily before you get into trouble with your cardiovascular disease? For that 35-year-old woman, it's 71 years. Notice that her 10-year risk of having a cardiovascular event is still vanishingly low at 1.9%. She would get sent away with reassurance by a 10-year risk factor guidance. Now, this is what's neat about this calculator. You can then dial down in front of the patient those individual cardiovascular risk factors. She stops smoking, she gets her blood pressure down from 160 to 130, she takes a statin and gets her cholesterol down from 7 to 4, and her heart age now actually gets down to lower than her chronological age. Look what happens in terms of a timing of her future cardiovascular events. She gains fully 14 years of event-free life prolongation before she can expect to get into trouble from cardiovascular disease. A huge potential benefit over her lifetime. Now, there are loads of screens in this calculator that you can use to try to get this message across, and some of them are useful for doctors and some of them are useful for healthcare providers. I like this screen here. It tells you what would happen if that woman took your advice but delayed starting the intervention for 10, 20, and 30 years. What you would see is that 12 years to 14 years of benefits you would get in terms of healthy life extension would start to get dissipated away, so that the later she started, the less benefit she would get. This again is the benefit from early intervention for lifetime risk reduction. Here's another example. This is a young man in his 40s, and this man decides to do something about his lifestyle. He's got a bit of hypertension, his cholesterol is a little bit high. So he changes his lifestyle enough to reduce his systolic blood pressure from 158 to 145 and get his cholesterol from 6.8 to 5.9. These are not dramatic changes. You don't need therapy, drug therapy, to achieve that. This is exactly what you can expect to achieve by sustained lifestyle change. If that man did that in his 40s, he would gain about a decade of healthy life prolongation. If that same guy presented to you in his 60s, and you now lowered his cholesterol from 6.8 to 4 by giving him a statin, you gave him antihypertensive medication, got his blood pressure down to 130, he would gain about 7 years of event-free life prolongation, substantially less than he could get by just lifestyle change done 20 years earlier. This is the balance between reducing risk factors in a sustained manner over long periods of time versus late interventions at high risk. This perhaps is the most controversial example, though. This is a 65-year-old man who comes along. He looks perfect. He's a non-smoker. He's got a very low cholesterol. It's 3.9. He's got a little bit of hypertension. His blood pressure is 150. And we calculate that man's 10-year risk. It's 10%, exactly the threshold that NICE would recommend starting a statin. Remember, his cholesterol was 3.9, his total cholesterol. If you now calculate the benefit of taking a statin, which might be expected to lower his cholesterol to 3.0, he would gain about 0.4 years of event-free life prolongation from taking the statin for the next 10 or so years. Very modest gains because it's quite late in the evolution of his disease, and comorbidities and comortalities begin to affect his life expectancy. So JBS3 is a very different way at looking at cardiovascular risk for the bulk of the population. It changes the interaction, we believe, between the medical profession and the population in primary care. It's personalized, it has a real emphasis on empowering lifestyle, and it's absolutely not just a statin conversation. Now here's the app. It's called Heart Risk. You can download it after the talk for free, and it allows you to all of these calculations on your own risk factor profile, which is the first thing, of course, everybody does. It's like a computer game, and you can play with it with your friends and family. And what it's designed to do is to extend this type of thinking about cardiovascular risk beyond the doctor's office into the population. Of course, we've got to implement this, and we've got to evaluate this, and this is going to be a major challenge at national level. We have already advanced negotiations with NHS England about linking the health check program that they advocate in people from the age of 40 to this type of communication platform, which of course works much better at the age of 40 than a 10-year risk. And we're going to have to evaluate the impact of not only measuring risk factors at 40, but actually trying to influence lifestyle and behavior and treatment on cardiovascular outcomes. One of the most interesting things that is beginning to emerge is the fact that the cardiovascular risk factors that we include in JBS3 as part of our cardiovascular assessment are precisely the risk factors that are important for other non-communicable diseases, particularly cognitive decline and dementia. There's now increasing evidence that what is now called preventable dementia is largely driven by variations in the same classical cardiovascular risk factors: blood pressure, diabetes, smoking, and cholesterol. So JBS3 and the approach we've taken in terms of lifetime risk really does potentially apply to other risk factors like dementia. And we're just in the point of developing and working with Public Health England to introduce a brain age and a brain aging tool based on cardiovascular risk factors. A publication that appeared last month really emphasized the potential importance of early management of risk factors for future risk reduction. This was the ARIC study again, looking at midlife hypertension and slopes of cognitive decline in a large population. And what they showed was the blood pressure between 40 and 60 had a very big impact on the development of dementia in the population, and actually produced a 2.7-year delay in terms of cognitive decline and dementia if you're at the optimal levels of blood pressure in middle age. Most importantly, blood pressure at 60 had absolutely no relationship with future cognitive decline. It was too late. It was the middle-aged blood pressures that seemed to be important. Now, this is Tom MacDonald's slide. He gives this to me. I love to show this because the big question about this type of lifetime approach is how early should prevention start? Clearly, when you've got familial hypercholesterolemia or other diseases that give you a lifelong tendency, starting in childhood is really important. And in JBS3, we make a very big play for managing cardiovascular risk factors in the young by teaching the family approach to beneficial cardiovascular lifestyles and early intervention in terms of lifestyles. And I think this is going to be a critical investment for the population in terms of future cardiovascular risk. So to end, I think we've done very well in cardiovascular disease management, but we've got a very long way to go still in implementing effective cardiovascular prevention. Our new guidelines in the UK support intensive treatment of cardiovascular disease patients and those who are at very high risk. There's really no difference between the European guidance, the new NICE guidance, the American guidance, and our JBS3 in emphasizing that reducing risk factors to much lower levels is likely to pay dividends. But what we do now is to provide a new personalized prevention framework based on assessing cardiovascular risk over lifetime. We call this investment in your arteries, and we believe that by early lifestyle changes, we may be able to attain substantial lifetime health gains for the population. And we think this will empower people to understand and take control of their own cardiovascular health. This is likely to be a major challenge in terms of evaluation and implementation in the population, but it represents a real opportunity to change the future cardiovascular risk, not just of our patients who are way down the road to developing cardiovascular complications, but also for us and the rest of the population. Thank you very much for your attention.
John, an absolutely fantastic talk as usual. I mean, you really blow us all away with that, and I'm sorry there weren't more people here to see it because it really is a great talk. Now, is there any questions for John? One here?
Yes, John, I enjoy your talk very much. I do want to blow other people's trumpet. The JBS3 is fine, but I personally find the CVD score very useful as well. It only gives, it's 3 numbers really. Apart from 10-year risk score, it gives a lifetime score, and also a ridiculously low score if you can treat or optimize all your risk factors. Essentially, a little bit simpler, and also the other advantage is that you can use it on people who are age 20 or above.
No, I've no problem with that at all. The New Zealanders also have a way of communicating lifetime risk, which to me is quite complicated, but equally gives the same information. The message is the key. The message is that if you do something early and sustain it, the small changes in cardiovascular risk factors early produce a leverage gain over your lifetime. And I think that's a really powerful message, and it gets us away from arguing whether 7.5% or 10% thresholds are important. It takes us away from accurate prediction of cardiovascular risk for an individual, because that message is true, irrespective of whether you've got the risk calculation correct or inaccurate by 10 or 20%. So I totally agree.
Professor Catapano?
John, I fully agree with the fact that I would prefer life expectancy without events compared to risk of dying lifetime. It is very sensitive, though, a point that always bothers me. That is, when you do start drug intervention, which is the threshold, especially if you start in younger ages. This is something that is somehow difficult to do, I guess, and is very sensitive and very delicate point, because as you move a little there, the population will blow up, and you will be accused of supporting, drugs and blah blah blah. What you will do?
Well, I think it's a good question, and the threshold of lifetime risk, or the aims in lifetime risk when you use drugs like statins and blood pressure-lowering medications, of course, still remains to be determined. One of the interesting things when we behave as doctors, we never ask the patients or the population what they want and what they think is acceptable. And that's one of the reasons there's been so much controversy. Suddenly, doctors have come out and said that 65 million Americans need a statin, without ever discussing that with the people who are going to take the medications. And we're surprised that most of them don't take the medications we prescribe. So I think this is a really astonishing way, a poor way of approaching a communication about what you want patients to do in the way that we've done it before. So I think this idea of empowering people to understand this concept of investing in their arteries and then making a decision whether they want to take a statin or whether they want to try and do better in their lifestyle, and seeing the benefits of one or other approach is a very intelligent way of trying to have that conversation. So that's the point. So it isn't that we need another threshold to tell people what to do, but I do believe that it's not a guidance that will be accused of being a statin guidance. It's actually an anti-statin guidance in a way, because we're telling people what they could do that may actually allow them to avoid taking statins in their lifetime.
Two last questions, one here and then one. Steve.
Thank you very much for a fantastic talk. I was just interested that you showed an image of a young boy doing a one-handed push-up, but you didn't mention anything about exercise within your talk and the importance of exercise in the context of
I had to talk for a short time. The problem with exercise, and if you read the JBS3, we really have a whole section on exercise. The difficulty with exercise is that we have no studies to allow us to predict the benefit of exercise that doesn't go through cholesterol, blood pressure, and weight reduction. So all of the benefits of exercise are factored in to our calculator through those other modifiable risk factors, because there isn't a study that allows us to dissect out the independent effects of exercise. But if you read the text of JBS3, we make a very big play for the importance of exercise and and healthy behavior in other ways over the life course of the patient. In fact, that's what we're really emphasizing. Steve? So I agree with you.
Steve Jackson.
Steve Jackson, thanks for a great talk. Practical question, when you put in JBS3 into the App Store, it takes you to QRisk and charges you 69p, but when you use your link, it says not available in the UK store.
Well, I didn't realize that. JBS3 risk, if you can do it now, you'll get straight into the JBS3 in the calculator. The heart risk is supposed to be free. It's supposed to be accessible on Android or the iPhone. Have a go at it. I've never heard people say that before. QRisk, of course, is the data set that we used. We used the open equations from QRisk to develop the JBS3. We modified it. We did some interesting things to the data, but it's essentially the QRisk population. QRisk, of course, is a commercial organization who will charge you for their data. JBS3 comes from the British Cardiac Society and is free. So if you've had trouble, I'm surprised, but I hear you, and that shouldn't happen.
John, thank you very much. That was an excellent talk. Well, ladies and gentlemen, that concludes the British Hypertension Society joint meeting with the Scottish Cardiac Society. I thought this was a fantastic meeting. I hope you've enjoyed it. We had nearly 300 delegates at one point. The society is, I know, we'll have to think about these closing sessions, I think. The society is in rude health, and next year is going to be Stratford-upon-Avon. I hope to see you there. I think we do need a volunteer next year to do a Shakespearean after-dinner spin, if anybody's interested. So we'll see you in 2014, and thank you all for staying to the end. It wasn't bitter at all. Thank you.